We're nearing the end of newborn stabilization. This is part 5 of 5. We put the baby back skin to skin with the mother after we complete the bath. It helps the baby to warm up and continues the bonding process. Now, there is evidence-based research that indicates the benefits of skin to skin care after cesarean, after birth, after bath. So see if you can click on that link to watch a video. If not, then you can just copy it and watch it later. We apply some type of an infant security device to all of the babies because we don't want anybody taking these babies when it doesn't belong to them. So some call it baby LoJack, some just call it the security tag, etc. So in addition to those little ID bands, the baby will have one of these on its leg. Every time you do an assessment of that baby in the morning, you need to record the number that's usually on the back side of it, and that gets populated into the chart. So you have to indicate the ID number, that usually five numbers or combination letter and number from the ID badges as well as the security device. Do not get these wet. I've done that once during a bath and it locked down all of Mission Hospital. Everybody comes running in and I'm sitting there with the baby's legs up in the air cleaning his little behind, and they said, "You set off the alarm." Like, oh, mea culpa, sorry about that. So try and keep it dry, and also do not get anywhere near the exit doors because it will also set off the alarms. Another thing that we'll do for the babies is use the TCB meter, transcutaneous bilirubin meter. You can see in the pictures on the right and the left that there are two different types. There's probably more than that, but we just scan it across the baby's skin, either on the forehead or on the chest, and we typically do the best of 3 and average them out. And you see the baby on the left? He is really yellow, and it doesn't help that he's got a little yellow outfit on because it really accentuates the pumpkin effect. And it is the nurse's job to determine, based on protocol, if the TCB is high enough that we will have the baby get a serum bilirubin as follow-up because we're trying to determine if the baby needs billy lights. Don't forget about the dad or significant other through all of this process. Dads can go skin to skin. Dads can participate in the bath. Dads can be present when you're doing your assessments and giving your medications. I hope you can't hear my cat meowing in the background. He wants to go into the garage. That's my Oliver. Look at these darling kids. They're having their newborn hearing test. We do this 24 hours after birth because we want to allow the fluid to exit the ear canals. So be real careful when you're giving the bath that you're not adding more fluid into the ear canals, which is already present just from being born. If a baby fails the test, we'll repeat it again in 12 to 24 hours. And if they fail again, then that's an automatic red flag. Refer to the pediatrician for a follow-up. Usually these kids are fine, but we're trying to find hearing disorders early because it affects their ability to interact with their environment and language development. You should be very familiar with the California Newborn Screening Test. It's actually a test that's done nationwide. So we do a heel stick, and there are 6 circles on this blotting paper. And we have to make sure that we completely fill each of the circles. And if it isn't completely filled, it will get booted out, and you have to stick the baby a second time. So we wait at least 12 hours, preferably 24 hours after the baby has been fed and within 6 days of age to collect this test and send it out to the state lab. If it is done too early, then there is a false positive possibility, especially in regards to PKU. In addition to doing the test, make sure you have the correct information about the parent's name, address, and contact information. If we get an abnormal test and cannot find the parents, what good was the test? And it may be 6 or 9 months before this baby finally presents to a pediatrician. By that time, they have a devastating outcome because we didn't do an intervention soon enough. Circumcision may be done. Some do it in the hospital while others do it in the OB office because of a cost factor. So I have a variety of slides here. The top left is the Gomco clamp that many of them prefer to use. The nurse is responsible for setting up the tray with the equipment that the physician needs and bringing the baby into the nursery. We usually do it in the nursery and put the baby on what we call a circ board. And there's pictures here of what it looks like before and after. After it's done, we want to put a very healthy amount of Vaseline on a gauze and put it right over the tip of the penis, and this prevents the diaper from sticking. The picture on the left shows it looks like the parent is giving the baby what we call sweeties, which is sugar water, and that is used as pain relief in addition to a nerve block using lidocaine that the physician will use. But you see the baby's legs are strapped down on the circ board, but he still has his little arms that are available. So you have to make sure that the baby doesn't flail and end up touching themselves and contaminating the sterile field. Make sure you look at your preclinical newborn record about when we expect this baby to void and what are the problems associated with circumcision and the important assessments to make. You're going to hear a lot about breastfeeding, and we expect all of you to attend a breastfeeding class. But because not all of you can go prior to going to the floor, review breastfeeding techniques, different holds, and the latch. You can go to the Stanford website to see additional photos of newborns. Primarily, they have some of the abnormalities that might be seen. It's got a nice collection, but keep in mind that some of the nursing interventions are no longer current, but the pictures are definitely valid. So this ends the series of newborn stabilization lecture videos.